I'm Dr. Khusboo Bisht, Assistant Professor in Department of Pharmacology at AIIMS Nagpur. And today I'll be speaking on this crucial but often underemphasized aspect of women's health, that is prescribing safety and polypharmacy in elderly females. In this session, I'll be covering a few physiological and pharmacological aspects of prescribing in elderly women, the burden of polypharmacy, practical strategies for safe prescribing, and the gaps in clinical trial with regards to inclusion of elderly women. So, the question is we can see two females. So, the question is, are we different? And elderly women, as we all know, that 80 is not 18. And thus, definitely, elderly women is different from a younger female. So now we need to understand the physiologic of aging is unique and it is not same as that we see in the adults. They also suffer from multiple chronic conditions, and aging does affect different organ reserves, and as a consequence it also affects drug handling. So let's look what actually changes when we are saying that there's a change in physiological reserve. So there's decrease in the renal function, increase in the body fat, decrease in the lean body mass, liver metab decreases, serum albumin decreases, and total body water also decreases. So we can see that as we are aging, the whole body composition as such is changing. But more important than the pharmacokinetic changes are something that we see in the clinics are the pharmacodynamic changes. So pharmacodynamic changes are actually we can see that when we are giving or prescribing a drug to a patient, a female patient especially, okay, because they'll come up to OPDs, with some complaints of maybe they're not getting sleep or something. So benzodiazepines are one of the agents which are very frequently prescribed in uh, elderly population, and especially females. Okay, so now here we need to understand that when we are prescribing a certain drug, it is not going to have similar kind of effect. It might have increased effect. So here also, when we are prescribing benzodiazepines, there's increased sensitivity in the elderly females. Likewise, for various other drugs that have been stated on the slides, we need to consider that the response that we're expecting, it will be it might be a bit more than what we expect in a normal adult who's not elder, or who's not an older adult to say. So, when we are talking about such changes, in each and every class of drug, there are certain drugs which will have differential effect. So, if we talk about tricyclic antidepressants, they'll have postural hypotension, and if we talk about hypnotic sedatives, they can induce confusion as such. Beta blockers, which are very commonly prescribed drugs, there also we need to understand that what are the actual adverse effect and how aggressively they can present in this kind of population, especially when we're talking about females. Again, we know that estrogen supplementations are sometimes provided. So there again we need to understand that what kind of interactions can occur in an elderly female differently from the male population, and we need to we need to really explore these area, because not much of literature is available even till date on the use of common drugs in females, and how they're going to react differently, or how they're going to respond differently to these drugs, apart from the routine interactions that we already know about drug interaction, drug disease interaction, drug food interaction. But then we should also we should also try to see explore actually what kind of drug gender interaction actually exists, and that is a gap in research as well as a gap in practical in practice, clinical practice, that needs to be addressed. So when we're talking about prescribing in general, we know that it becomes a bit problematic, especially when we talk about older population, and then it becomes a bit more tricky when we talk about elderly women. So first and foremost, whenever we are prescribing in elderly women, we should set our goals of care. We should see what type, whether we are expecting a long term benefit, a short term benefit. Okay, and most important is the dose. So it's a general prescribing trend that needs to be followed in elderly, that you start slow and then you start low and then you go slow. So because we don't know what will be the response, whether it will be because in elderly they are already receiving, as we already know that they suffer from multiple comorbidities, and that's why they'll be receiving n number of drugs, maybe 2 3 or sometimes more. And when they are receiving more drugs, we need to be more careful. Thus, monitoring is very important when we are talking about prescribing in elderly women, because most of the times, if you see in the clinical setups, these females, they'll come with joint pain and other things. So NSAIDs are something that are very commonly prescribed and consumed among this population. Again, NSAIDs have n number of interactions, n number of adverse effects that again need to be addressed. And what happens when we prescribe such kind of drug is that a prescribing cascade sets in. Okay, thus monitoring of the prescribed drug is very important. So whenever a patient is coming and you have made an initial prescribing decision, now it's very important that we educate this female about what she needs to understand about the medications and the problems that are actually related with the medications. And once this education has been imparted, then one needs to monitor for side effects. So patient may or may not monitor see these side effects, but then we need to monitor the side effects along with the effectiveness of that drug. And adherence is another part that needs to be taken care of, which will be taken by Dr. Shambhu sir. So assessment at each and every level when a female is coming to your OPD, because we need to know what they're consuming. Now in India, especially when we talk about females, so they are they are very experimental in nature. So they want to try different kind of medications, especially the herbal ones. So we need to take this medication history again properly and see what kind of drugs are actually being consumed by our elderly females. Because when they're not getting relief with the symptomatic relief, by one or the other drug that is prescribed, it is likely that they tend to go to other kind of therapies, maybe ayurveda, maybe homeopathy. And this part also needs to be explored or checked upon by the treating physician. Now once you have everything, all the information about this female in your hand, then again you make up the decision, and during the follow up, that what kind of drug needs to be continued and what needs to be changed based on the response of this female, and also based on the newer drugs that she might herself have added to the prescription that you have provided. So, when we're talking about comorbidities, we are talking about elderly female. We know that she is going to come to you. You yourself will be prescribing maybe more than five or six drugs, or maybe less sometimes. However, when we talk about polypharmacy as such, it has been described by WHO as concurrent use of multiple medication, maybe more than five. So, whenever a patient is receiving more than five drugs at a single point of time, we say that this patient is undergoing a polypharmacy. Now, when we're talking about polypharmacy, elderly women, they'll be more prone, because they will be having multiple chronic illnesses, as well as sometimes healthcare, access to healthcare patterns also become problematic, because we know that especially, females, they have their, if we talk about Western world, again, there's delay in getting appointments and consultation. And sometimes when we talk about the other part of the country, or other part of the world, where healthcare access itself is very difficult, people living in remote area, so they tend to take different medications. And at then when they're landing up at your clinic, you might yourself prescribe, depending on the comorbidities and other condition, few other medications. So definitely most of the times it rises, the number of medications, it rises to more than five, uh, accounting for the prescribed, the OTCs that have been taken by the female herself, some traditional and complementary medicines from the traditional and complementary system. So these will again contribute to pharmacy. So that is why when we are talking about polypharmacy or assessment of prescription, That time, apart from what we are prescribing, we also need to take care of what they are themselves prescribing, based on their symptomatic needs.
So,
So
Dr.
when we talk
Khusboo, Dr. Khusboo, can I request you to summarize the slides? Maybe in one
about,
minute.
okay. So when
Thank
we're
you.
talking about level of polypharmacy, so there are different levels of polypharmacy that one needs to understand depending on the number of drugs. There are different types of polypharmacy which are deemed to be either appropriate or inappropriate. Now, whenever there is inappropriate polypharmacy, it needs to be addressed uh, based on different risk factors that a patient might carry, and the outcomes of such polypharmacy can be multiple, starting from drug interactions to mortality. And prescribing cascade has already been discussed by Dr. Shabnam ma'am, so I won't go into it. So basically, the question is that which drugs need to be routinely considered when we are talking about elderly female patients. So old as well as newer drugs needs to be considered. Then good prescribing in elderly women will take into account regular medication review, checking all the drugs, and simplifying the drug regimens as well. There are different quality indicators of drug prescribing, starting from quantitative indicators, qualitative indicators, and evidence based indicators as well. And there are multiple tools that are available in literature, and which have already been in practical practice, which can be used for checking potentially inappropriate medications as well. So, when we are talking about prescribing in hospital or during the end of life care, okay, it's important that we take into consideration, the needs of patient, and we keep our drugs to minimum. Talking about the clinical trials in elderly women, often we know that women as such are underrepresented, and when we talk about elderly women, definitely there is more underrepresentation. So there are few do's and don'ts that one needs to consider. Whatever I have talked about in the previous slides, that we need to simplify the drug regimen, start low and go slow, assess the drug for its effectiveness, and we need to ensure that a patient is adhering to whatever you have prescribed and not self-medicating him or herself. Uh, so the take-home message for today's talk will be that we need to consider the multifactorial origin of the disorder and the multifactorial interventions that a patient is receiving, especially taking care of the symptoms that are arising, or the adverse effects that are arising from medication. You need to take a call whether it needs to be treated further, or stopping the drug for some time will be adequate, and rather than ending up into a prescribing cascade. So just to end, I would just say that we are all are going to die someday, but it's important that we live every other day, and that is more important for females. So let's make each day healthier and safer for elderly women by prescribing safely and thoughtfully. Thank you.